My name is Jeannie Kim, and thank you very much. Yes, I'm one of the GYN minimally invasive surgeons at Columbia. Thank you so much for the opportunity, Dr. Sechkin, the Endometriosis Foundation. And also thank you, Dr. Jayan Shin, for providing some of the videos, although I'm hearing that we may have a little difficulty, so we'll see what we can do. Thank you. So just my disclosure. And then just in terms of the more typical areas of endometriosis, as you might all be aware, is usually in the pelvis, which is most commonly in the posterior cul-de-sac, ovarian fossa, ovaries, anterior cul-de-sac, bowel, appendix. And in today's talk, I'm going to focus more on endometriosis disease outside of the pelvis. So even if the endometriosis invades the bladder or the bowel, outside of those organs. So in terms of objectives, we'll discuss some of the types and locations of extrapelvic endometriosis using some case presentations, and namely these 5 areas. And we'll discuss the diagnosis and treatment and preoperative considerations. And also we'll try to review some of the current literature. I have to point out, though, that there is probably a dearth of literature in this area. So a lot of the literature is mostly case series and case reports. So just the first case, a 27-year-old pair 3 with 3 prior C-sections last 2 years ago, 3rd pregnancy complicated by retained POC and postpartum hemorrhage, requiring a DNC and a transfusion. She presents with a 4-centimeter mass, 3 centimeters above her cesarean scar on the left side. She reports non-cyclic pain and swelling. So I think in terms of differential, it probably may depend on who you're seeing and whether you're a general surgeon or a GYN surgeon, but we do have to think about many things, including incisional hernia, hematomas, granulomas, abscess, and soft tissue tumors, either benign or malignant. But as a GYN surgeon, we should also think about abdominal wall endometriosis, and I'm sure many of you have seen this in your practice. And in terms of abdominal wall endometriosis in a prior C-section scar, the incidence is roughly 0.03 to, in some reports, up to 1%, up to 0.5%. So it's not a common occurrence. And it's thought to be iatrogenic seeding of endometrial cells upon delivery at the time of C-section. And there usually is a palpable tender nodule, nodular mass that can be either cyclic or non-cyclic in terms of pain, and it's typically near the cesarean scar, but it doesn't have to be at the cesarean scar. And typically, MRI of the abdomen and pelvis may give you much more information. So this is an example of an MRI. As you can see the mass that's in the circle. But it can be many other things. So typically the treatment is surgical excision for definitive diagnosis and treatment. And there are sometimes one can apply medical treatment, especially if it's not so bothersome to the patient or if it's very small. But the disadvantage is that you don't have a pathologic, histologic diagnosis. So the typical sort of treatment recommendation would be surgical excision for diagnosis as well. And at the time of the surgery, it's important to get a disease-free margin. So like adenomyosis or adenomyomas, similar to that, these masses typically get very stuck within the subcutaneous tissue. And the preoperative testing with the MRI would also give you the information about the size and the location in terms of how close it is to the actual fascia. So in terms of whether or not you want to consult your fellow general surgeon for possible for a possible mesh excision or mesh placement if it's a very wide area. And you might want to consider concurrent laparoscopy, especially if the patient does not have a prior pelvic endometriosis diagnosis. And like we discussed, medical hormonal therapy is probably less recommended than surgical. So this is so I may have to just show the videos at the end. I'm just having a little bit of technical difficulty here. So in terms of abdominal wall endometriosis in a prior cesarean scar, Again, a retrospective chart review in 2010 by a general surgeon. It was a case series of 40 patients, and cyclic pain was noted in 40, non-cyclic 45, so about the same. And the mean duration of symptoms was about 18 months before surgery was performed. And it's interesting that the pre-op diagnosis was correct in only about half the cases. And the reoperation rate is also notable, 9% in terms of residual disease that had to be gotten at a later time. Another retrospective case series of 12, again, another general surgeon. This was a little bit older in 2003, but again, similar breakdown, cyclic, non-cyclic, so it doesn't have to be cyclic pain. And the mean duration of symptoms, again, about 2 years prior to surgical treatment. And again, the pre-op diagnosis was even a bit lower, 33% correct, and 16% required mesh. And they did report that within the follow-up period of up to 3 years, there was no recurrence. But again, the data is, again, not the most robust. This is published by a GYN, OBGYN, looking at 18 cases, and essentially in this cohort of patients, there was more non-cyclic pain. And in terms of, you can see the varying ultrasound, CT, MRI diagnostic methods that were used. And in terms of their surgery, their mass size was about 4 centimeters, and they did report recurrence in 2 years, and no recurrence in 2 years. But their diagnostic capability was, they report, correct in all cases. And there's some few reports of malignant transformation of these endometriosis found in the prior C-section scar. And again, they're basically case reports of these patients. One is most recently in 2012 of a 49-year-old with progressive growth of a C-section scar mass with pain for 25 years. And surgical excision confirmed clear cell carcinoma. She received the appropriate chemotherapy, and she was free of recurrence in 8 months. Again, that's a short follow-up. But malignant transformation from an abdominal wall endometriosis is extremely rare. And there were 22 cases reported in the literature. So moving on to a different case, a 30-year-old para 1 with no prior surgeries. She reports cyclic umbilical pain and bleeding. And as you can see here on exam, there's a 1 centimeter nodule on her umbilicus that is tender to touch. So in terms of differentials, we would think about potentially other melanoma, keloid, fistula, abscess, hernia, maybe a soft tissue tumor, benign or malignant. And we also do have to sort of think about umbilical endometriosis, even if it's someone who has never had surgery before. So there is primary umbilical endometriosis, again, not very common. And literature is based on case reports and patients may present with cyclic pain, nodule, and spontaneous bleeding that correlates with her menstrual cycle. This is just a CT showing a mass. And in terms of treatment, excision is, again, touted as the definitive sort of diagnosis in addition to treatment. And if it is difficult to see because it's 1 centimeter or sometimes it gets much smaller, you do want to time your surgery at the appropriate time so that it's the biggest so you can actually see the mass. And again, considering laparoscopy if there's any concurrent symptoms and especially if there's no prior diagnosis of endometriosis in the pelvis. And you may want to consider a plastics consult. I mean, you are essentially removing the actual umbilicus and the stalk as well, so there may be obliteration of the umbilicus. And again, surgical therapy is usually preferred over medical. So this is an example of pre and post, and again, there is a video that I don't think is working for whatever reason, but I'll try to find it and play it back. So moving on to port side endometriosis, similar in terms of umbilical endometriosis that's primary, but this is in patients who have had prior surgery. So again, this is a recent 2015 case report. This is a patient who has had 2 laparoscopies for endometriosis. The last surgery was 3 years ago, so it was quite a few years ago. And in terms of diagnosis, ultrasound, MRI, and there was only 16 cases of this reported in the current literature. And it's been found to be present after potentially laparoscopy with the endometrial tissue seeding, endometriosis tissue seeding, cystectomy, appendectomy, myomectomy, cholecystectomy. So there's another case report of an ovarian remnant syndrome in the port site. So this is a 22-year-old with a history of a laparoscopic USO for an endometrioma 5 years prior. And after excision, they saw ectopic ovary on the pathology specimen. And ovarian remnant syndrome is a rare GYN condition, but something to sort of have in the back of your head. And obviously, there are many things that you could do to reduce the risk of port site seeding, using a bag, having it intact, perhaps irrigation, making sure that your pathology is not really touching the skin area. And there is consideration for coldotomy if it's patients in terms of not having it seed, but potentially I suppose you could seed it in that area as well. So moving on to our third case, 34-year-old para 1 with a history of a left mediolateral episiotomy. She has had multiple ER visits for a lump type of pain. And on exam, she has a palpable tender nodule at 7 o'clock. So I'm probably not going to spend too much time on this because I think there's a following talk on vaginal excision of endometriosis. But in terms of differential, I'm thinking about in the vaginal area, obviously abscess infection, condyloma, Bartholin cyst, cancer, benign mass is also a consideration. But in someone who's had a prior episiotomy, potentially we do want to think about vaginal endometriosis. So again, it's based on case reports, but most commonly reported with a history of episiotomy, not necessarily all the time. Typically, patients present with a cyclic pain and nodule, and there's a possible delay in treatment with misdiagnosis. So a full excision sometimes may not be possible depending on the location, but the recommendation is to try to excise it as much as possible. So I apologize. I'll do the videos at the end. So fourth case is a 33-year-old G0 spontaneous pneumothorax after the onset of menses. And the differential in terms of what we can think about these are probably what the pulmonary doctors see more so than us, but lymphangiolymphomatosis, pulmonary Langerhans cell histiocytosis, other things. And we do want to think about catamenial pneumothorax. And I'm sure many of you may have seen this. And typically it starts within 72 hours after the onset of menses, and there's chest or scapular pain in most patients. Dyspnea, typically it's right-sided, and frequently the recurrence is due to a delay in diagnosis. And it's important to sort of elicit prior episodes and timing with the menstrual cycle. And in terms of diagnosis, typically, patients present with a pneumothorax and a CT of the chest would be helpful in terms of looking at this. But however, thoracoscopy is probably the most accurate way of actually taking a look and possibly biopsying. So treatment, again, treating the immediate pneumothorax with a chest tube and secondary blebectomy, therapeutic pleurodesis. Sometimes if the hole is too big, you have to do a diaphragmatic repair with mesh. And hormonal suppression is oftentimes recommended for 6 to 12 months. And recurrent pneumothorax is as high as 40% after the combined VATS procedure and the hormonal suppression. So there are at high risk of having this again, despite doing all the things that we do to minimize that recurrence rate. So just quick literature review, 2007. In this series, 24% of the patients who had this type of VATS procedure actually had catamenial pneumothorax, and 18 of them had histologic confirmation. The important thing is that you don't always need histologic confirmation if your suspicion is high enough. And in these patients, 6 months of Lupron was given with a mean follow-up, and the recurrence rate was about 30%. Another smaller case series, sort of showing sort of similar information. So the last but not least, in terms of other areas where endometriosis can occur, just to put it out there in terms of CNS locations, including the cerebellum and the cerebrum and the spinal cord as well. So a patient with a gait disturbance and headaches, history of congenital hydrocephalus, had multiple shunt revisions since her first VP shunt at the age of 2 months old, and last was 2 years prior. So this MRI, T2 weighted image, shows fluid cystic levels similar to what we might see in the pelvis, like an endometrioma. And after surgical excision, the pathology confirmed endometriosis. And there are 3 other case reports sort of documenting similar types of endometriosis seen in the CNS system. So just a quick summary. It's very important to do a thorough H&P. So in terms of painful cyclic palpable mass, when does it occur? It doesn't have to be cyclic. Also obtaining that surgical history and obstetric history. And also the review of systems is extremely important. In terms of preoperative planning with imaging, MRI is usually touted as the most preferred way to aid in diagnosis and also to evaluate the involvement of the surrounding tissue, whether or not it's close to fascia, in the case of the C-section ectopic, C-section abdominal scar. And in terms of consultation,